Hello, everybody. Dr. Spencer here again. We're going to be talking about trauma and stress-related disorders, uh, adverse childhood experiences, and crisis management. I've kind of grouped those all together. Some heavy topics here, but very interesting, and I think you'll enjoy learning more about these. So, acute stress disorder, what is it, and what do we need to think of when we're encountering young people with this disorder? Well, acute stress disorder is diagnosed when a child or youth experiences symptoms including, say, intrusive thoughts, negative mood, dissociative symptoms, avoidance or arousal symptoms after a traumatic event. And it's important to remember that the symptoms cannot predate the exposure to the trauma, and the symptoms are from 3 days to 1 month or less immediately following that traumatic event. And then young people with acute stress disorder may experience catastrophic thoughts, panic attacks, guilt related to the event. Um, they can have some separation anxiety. Their symptoms can kind of be like post-concussive symptoms, maybe headache, sensitivity to light, difficulty concentrating, irritability, dizziness. All of that is common, even though they haven't had a head injury per se, or um, maybe didn't have any type of physical injury. The incidence of acute stress is higher in clients who've experienced interpersonal trauma, such as an assault or rape, compared to those who experience a traumatic, say, motor vehicle accident or an industrial accident. And remember, they have to be in four domains. So, in dreams or other intrusive symptoms, avoidance of memories, negative moods, thoughts associated with the trauma, and changes in arousal. And I took all these from your textbook, but you can find all of this obviously in the DSM-5. But I loved how our textbook just kind of um, scoped these down for us so they weren't so huge. And then let's look at um, post-traumatic stress disorder now. So again, symptoms cannot predate the exposure to the trauma, and we know that the symptoms have to now be greater than 1 month. And there are three different subtypes. There's the acute duration, which is symptoms of, say, less than 3 months. There's chronic, and that's symptoms lasting 3 months or more. And there's maybe a delay that's at least 6 months between the traumatic event and the onset. And the consequences of PTSD include social, occupational, and physical impairment, physical health problems, reduced quality of life, and increased risk of suicides. Um, and people with PTSD are more likely to present with comorbid psychiatric disorders such as major depressive disorder, anxiety disorder, and substance use disorder. So, because of this comorbidity, it's always the rule, if, as your textbook points out, with juvenile PTSD, that you ask about symptoms that might allow for additional diagnoses or any misuse of substances. And you're assessing for, separation anxiety, attachment disorder, um, disinhibited social engagement disorder. Very important, again, to assess for that. And traumatic experience are in children are a significant risk factor for the development of later onset of psychopathology. So, really working with these young people to identify this and getting them the help they need is very important as you're working with this population, obviously. I really like how your textbook, the Interviewing Children and Adolescents by Morrison and Flegel, has this nice outline of comparison of PTSD in preschool children and older children, and they compare it to the acute stress disorder. So I took it right out of the book here, and that's on page 307. It was much easier than trying to reinvent the wheel because I really think they did a nice job pulling this all together. You do want to look at your DSM-5 and of course go through that, but they've just made it more brief here for you. So they're talking about, say, trauma that you can either direct experience, witnessing, learning of it. So if they hear about, say, the death of a parent, that can be very traumatic. Repeated exposure, and not just TV, right? And then they have to have 1 or 5 of these symptoms here, intrusive symptoms. 1 of 2 of the following, either avoidance, negative emotions, they have to have 2 of the 7. And then physiological, they have to have 2 of the 6. And then this is for young children, and this is acute stress disorder here, you can see. And this is in your textbook. Excellent resource. I'd refer to that and kind of know what those are so that as you're working with this population, you're able to diagnose better and provide the proper treatment. There are some nice screening tools available for PTSD, especially in children. I've included some links here. There's this clinician administered PTSD scale that's actually from the VA, but they have a child one. And I put a link here. You can actually do an interactive simulated training on how to do that. And they have one for adults too, but they do have a child one. Really a nice resource. And then there's a child/adolescent trauma assessment. I put a link there for you here, where you can look into those if you ever want to do those. Remember, these are just screening tools. And so for treatment, the recommended treatment is trauma-focused cognitive behavioral therapy, TFCBT, or child-parent psychotherapy, EMDR, especially in our adult population, but it's being studied for children. EMDR is very effective for the treatment of PTSD. And then you can use medications. There's some question if they really do work, but I think if there's underlying other psychopathology, such as depression or anxiety, you may want to treat those, and that could be very beneficial for the young person as well. Okay, so I know we've all heard a lot about adverse childhood experiences, ACEs. I wanted to go through this real quickly. What are they? What do we do? One of my frustrations, I think, we hear about this, we know what it is, but how do we treat it? What do we do about it? So I wanted to quickly touch base on that as well. So adverse childhood experiences, or ACEs, are potentially traumatic events that occur in childhood, 0 to 17 years. For example, experience of violence or abuse or neglect, witnessing violence in the home, having a family member attempt or die by suicide. And then we're looking at growing up in the home where there's substance use or mental health problems, instability, separation from parents, such as being in jail or prison. And this is not a complete list. I took these from the CDC here for you, but I do think it provides a nice brief overview of what those are and how children experience those. And we know that as the more ACEs they have, their increased risks of adverse outcomes. So they have early death, disease, disability, and social problems. So we know that the greater the risk, the greater the impact when it comes to these positive ACE scores. And then children or youth who have high exposure to adversity need to receive support and to prevent some of these lifelong consequences. I brought this nice fact sheet in for you from a really good website, which I'll share with you later. It's Turning the Tide for Traumatized Children and how to do that. It's really nice resource here. You can just look at that and review the information there. Some screenings for ACEs. There's several of them out there. These are ones for children. This is from the Center for Youth Wellness. That's CYW. That's the ACE Q. That's for child. And then there's the ACE Q for teen. And then the pearls. I think that's a parent something questionnaire for 0 to 11. And then there's one for 12 to 19-year-olds. And there's also an adolescent self-reported screening questionnaire. Now, remember, these aren't diagnostic. These are screenings that you can do. And so what's some of the treatment? I spent a lot of time putting this together. And I've actually really enjoyed doing this because I've learned quite a bit myself and finding some really amazing resources out there. So some of the treatment are applying principles of trauma-informed care, including establishing trust and safety and collaborative decision-making, even if they're a young child, you're working with them and try to collaborate with them and, interviewing them and talking to them. And maybe if you're, doing some type of psychotherapy or play therapy, you really want to collaborate with them, and depending on the situation and the setting. You might find it easier to do that. And then supplementing usual care for ACE-associated health conditions. So like to helping develop supportive relationships um, with the with other family members, making sure they're getting good sleep, balanced nutrition, physical activity, mindfulness, exposure to nature. I believe that's so important. Mental health care, including psychotherapy, or which you guys are doing, psychiatric care, substance use disorder treatment when indicated, getting children off of social media. There are nice guidelines out there. I didn't include them in here about how much per the age a child should be on social media, and just having those discussions with parents um, in a non-judgmental, supportive way. Many parents, maybe people don't know that, and I know for a fact that social media is used as a babysitting tool for many parents while they're trying to cook or do other things if they're a single parent home. But finding other ways that you could help them to learn how to include the child in things that the parent's doing. Um, and again, a non-judgmental way that would be helpful to build those relationships with the parent and the child. Finding a really good therapist, child therapist that you can refer to would be awesome as well, or get some additional training as a child therapist. Would encourage that as well. It's out there, you can do it. So I would encourage that if you really want to work with children. So now we're going to talk a little bit more about some more serious topics. So non-suicidal self-injury, NSSI, and suicide. I wanted to share some statistics with you about this. So suicide is the second leading cause of death among people 15 to 24 in the US. Nearly 20% of high school students report having thoughts of suicide, and 9% have made an attempt to take their lives. Indigenous communities, such as Alaskan Natives, have higher rates of suicide than the general population. And then youth who identified as LGBTQ also have higher risks of suicide than the general population. I put this nice infographic here. I'm going to include this document in the course for you, but Navigating a Mental Health Crisis, that's from NAMI. It's a nice resource for patients that they could use. I also found this amazing book that I wanted to share as I was preparing for this lecture and this course. It's Suicide Prevention, Stahl's Handbook. So if you remember your psychopharmacology class, Dr. Stephen Stahl wrote those texts, but he's collaborated with some other people on this textbook. It's excellent. It doesn't deal just with youth suicide, but it deals with suicide in the older population and all kinds of different cultures. So excellent book. I bought it on Amazon. Very, very good. I used it a lot in preparing for this course. And here, 1 in 4 Americans who have a mental health condition in their lifetime, and 50% of those conditions have their onset by age 14. 75% by age 24. Girls are more likely to attempt suicide than boys, but boys are more likely to die of suicide than girls. Although this is decreasing, and girls are starting to, unfortunately, catch up to boys in that statistic. So let's spend a few minutes talking about non-suicidal self-injury. I see this a lot, shockingly, in my practice. And I have to tell you, I felt woefully unprepared to intervene in this. I've asked about it, but really was not, when I first was starting, not prepared how to deal with it. Didn't understand it too well. And I found this society as I was preparing this lecture and stuff for you guys, the International Society for the Study of Self-Injury. I will put links to all this stuff at the end of the lecture, and you can have that. But what is non-suicidal self-injury? Well, it's defined as deliberate, self-inflicted destruction of body tissue without suicidal intent, for purposes as not socially sanctioned, including behaviors such as cutting, burning, biting, scratching. Non-suicidal self-injury, like cutting, burning oneself, is more common than suicide attempt, all right, and occurs roughly about 70 to 8% in adolescents. Um, and while it is often described as effective to relieve distress, it has been found to predict suicidal attempts and a later death by suicide. So, we sometimes think that an SSI is not as serious, but I think it is a precursor. And the studies I was reading does definitely make that clear that it can be a precursor to suicidal thoughts or suicide. And even when a patient denies suicidal ideation when engaging in NSSI or self-harm with unclear intent, the patient risk is considered elevated due to increased risk of later, more dangerous self-harm behaviors. And I put here some key elements to the definition that the International Society provides, and I thought I'd share that with you. I won't go over all of them in depth, but the harm is intentional or expected. The injury results in immediate physical injury, is not intended to cause death, and is not part of social or cultural practices. What are some common risk factors for suicide? Well, quite a few things have been associated with that. Prior suicide attempt, family history, history of mental health conditions, such as severe depression, anxiety, substance abuse, impulsivity. So again, you're assessing for all of these when you're meeting with someone, and they maybe not all of the time, but if they report feeling suicidal or you have a suspicion, you'd want to be assessing for this. Are they socially isolated? Have they had multiple exposures to suicide in the community? We see that a lot. And while the risk factors above might not increase someone's long-term risk for suicide, there are several things that might indicate someone is considering suicide. And I took these from NAMI's website. Joking about it, feelings of hopelessness, extreme sadness, withdrawal from others, changes in substance use, seeking means to self-harm. And it's important to consider what are some positive factors too, and raise those factors when working with young people. Encourage them, just saying, hey, I appreciate how you have some effective coping and problem-solving skills. You work really hard at solving things and taking care of things. You don't want to praise someone for how, say pretty or nice they look, but praising them with, using verbs or saying, you work so hard at something, you really got in there and did a nice job doing this. Having strong social support, access to good quality mental health care, religious support is good. And then if there's a lack of access to means for self-harm, such as guns and other things, those are some protective factors to consider and assess for. some screenings. The PHQ-9, not the 2, but the 9. It's not a suicide risk screen, but it can show changes in mental health. I routinely screen all of my patients for using the PHQ-9, no matter who they are. Every patient gets this up to their age, 12 and up. And then for suicide screening, there is the Columbia Suicide Severity Rating Scale, which you guys in your adult class had exposure to. And then there's the Ask Suicide Screening Questionnaire, which in the next week, I believe, you'll be doing an assignment on utilizing this. So you get some training on that. And that's geared toward young people. It's a nice screening tool. And then there's a brief assessment tool that goes along with it. And like I said, you'll be getting some training on that. So what's some treatment for non-suicidal self-injury? And again, I took this from that suicide prevention book. I took it right from them. So treatment should consider the broader clinical picture of what could be going on with the person. So why are they cutting? Why are they burning? Is there abuse? Are there other things going on that we need to be assessing for in the home? Substance use, have they been assaulted or bullied? All those things. So consider the broader picture. But some of the treatments can be DBT, CBT, mentalization therapy, family therapy, and elements across the therapeutic modalities that are most effective include incorporating coping skills and safety plan, assessing negative thoughts, emotional regulation, de-stressing tolerance, interpersonal skill building, and increasing social isolation. Increasing social connection and support. Those things that's part of the treatment for non-suicidal self-injury. And then for suicide, some of our suicidal thoughts and some evidence-based things you can do for reducing suicide risk and alleviating distress. There's safety, that's a DBT informed cognitive treatment that's been shown to be effective. There's a youth nominated support team intervention for suicidal ideation and adolescents. There's an adolescent version. Integrated cognitive behavioral therapy was found to be effective. Mentalization therapy, CBT for suicide prevention has been shown to be very effective. And lethal means counseling. Remember how I talked about how we need to assess for lethal means. So doing some lethal means counseling has been shown to be effective. And these were all based on research. And again, I took that from that suicide book that I was talking to you about. These are all direct quotes, by the way. Some clinical pros. Again, I took this directly from the American Academy of Pediatrics website. They recommend, evaluation and management of suicide and self-harm using this 4-step process. I kind of liked it. So ABCD: assess the risk, build hope and reason for living, strengthen connections with protective adults, and developing a safety plan. And the screening tools, like I shared with you, the Ask screening tool. Traumatic stress, as we shared, is associated with increased risk of suicide. So assessing for that, working on decreasing that. And then they recommend that every practice and clinic is different, and you should develop an approach that fits your practice and the resources. And some clinical takeaways. Again, I took this directly from the suicide prevention textbook because I thought it was so helpful. Returning screen for mental health conditions in pediatric patients, screen for suicidal ideation as indicated, or routinely screen 10 and up using the Ask questionnaire. Make time and a safe space for patients to raise their struggles. So getting a young person away from their parent, allowing them time to talk and share what's going on. Increase your radar and sensitivity for detecting distress or deterioration in mental health in young people. Using open, kind, non-judgmental communication, and asking about suicidal thoughts. Remembering that an assessment of a patient's suicide risk does not stop with suicidal thoughts or plans. So you always have to consider their past history, stressors, substance use, the clinical course. Is there a family history? What are their coping strategies? And what are their support? These can all play into the risk of suicide and suicidal thoughts. Incorporate the topic of social media, like I shared earlier, into clinical history taking and discussion with patients. Training clinical and non-clinical staff in suicide prevention. I've been working on that where I work, getting everyone trained on this, on suicide prevention, incorporating safety planning and lethal means counseling, and then following up. So do you have to call them, text them, make yourself available? There's crisis referrals that you can give information. They can call the crisis line 988, or they can text. And then educating parents on supportive behaviors in the home for children and teens who are at risk. Many parents are just as distressed and don't understand it either. So maybe even getting the parent alone, getting the parent into counseling can be extremely helpful. And here's another infographic for you that's from the American Academy of Pediatrics, which, by the way, they have some amazing resources I'm going to show you here in a few minutes that I think you might find very helpful. And I've provided some links for all of that. There's 988 crisis line, and then there's the text support crisis line. And so we're going to spend a few minutes just looking at some of these resources real quick. The American Academy of Pediatrics has, excuse me, some wonderful resources here. You can see just great stuff. If you haven't used their stuff, I would recommend getting into that. They have all kinds of great materials. And this was the Pediatric Mental Health series. It's about 16 minutes, a video that was done. You'll be getting trained on this coming up, the Ask questionnaire. The Child Development Association has a bunch of really good stuff about ACEs and how to work with people, and I think you might find that helpful. This is where I showed you that infographic was about ACEs and stuff. The Child Welfare Information Gateway can be very helpful. I like this site a lot, youth.gov. Some really good information on here. Center for Child Counseling, I think you might find helpful. Let me go back one page. The Center for Youth Wellness. By the way, I put a video in the introduction by Dr. Nadine Burke. It's a wonderful, I hope you'll watch it. It's a TED Talk she gave. I also recommend reading her book on adverse childhood experiences. It's called The Deepest Well by Dr. Nadine Burke. I know you guys don't have a lot of time, but if you can listen to it, excellent book. I've listened to it several times about childhood adversity and what we can do to help. So Center for Youth Wellness, great resource. The ACEs Aware, again, a nice resource for you. Navigating a Mental Health Crisis by NAMI, and you can download this guide. I'll put that in there for you. Here's the VA site that I was talking about, and you can get the training for that PTSD screening if you're interested. It's really nice. I believe it's free. The International Society for the Study of Self-Injury. I didn't even know there was such a thing, but I'm glad there is. And I didn't know until I was preparing for this course. So I'm glad we have access to something like that. Let's see here. There's a crisis text line that you can use. There's some fast facts on ACEs. And oh, I really like this one too. The American Society for Positive Care of Children. They have a really nice document about ACEs that you can use and its treatment. And I'm going to share that with you in just a second. The American Foundation for Suicide Prevention, another great resource. I encourage you to get involved with that. All of us should be up to date and aware of these things. And then the 988, the crisis line, is an amazing resource for you as well. So here's a nice Understanding and Preventing Healing ACEs from, again, the American Society for the Positive Care of Children. You might want to access that. It has a lot of really, really good information in it. It's a little too big here. Sorry. Shrink that down. Really good information and ways to help, strategies you can use and work with, and what it means, caring for kids, prevention. Excellent, excellent resource. The ACEs Aware is a nice resource as well, that how to screen for ACEs and help children. The CDC has a resource out, the Adverse Childhood Experiences Prevention Strategy. So prevention, remember, that's always key. We got to think about prevention. And then this was a nice infographic from the CDC on ACEs and what they mean, what they are, and what it does, and the impact, and how it impacts families and children, and how do we heal from this, and what we can work on doing for everyone with these. So again, I'm leaving you with these are the references here that you can find some of the information on. But again, it's some really nice resources that I hope you will take advantage of and look up. And thank you.